If we want to talk seriously about neural rehabilitation, we must sit at the same table with engineers and doctors. And this is why I went to Milan, and this is why I interviewed together Professor Alessandra Pedrocchi and Dr. Franco Molteni, an engineer and a doctor. We talked about psychology, neuroscience, and electrical engineering. All of this together combined to design better therapies and devices for people with reduced mobility or stroke survivors. I hope you'll enjoy this episode. Alessandra and Franco, it's great to have you both here.
Happy to be here.
It's a pleasure.
Alessandra, you are an engineer at the Politecnico in Milan, but today we're not in Milan. We are somewhat 1 hour away, not in a place of engineers, but in a place of patients and caregivers and doctors. This is a rehabilitation clinic, and much of your research is carried out here. Tell me the importance of this place for your research and the importance of having a collaboration with such a nice clinical facility for a team of engineers.
For us, it's really essential to be here. We are developing technologies for rehab, and for 10 years we have been working in a lab inside this clinic. So there is one premise of our neuroengineering and medical robotics lab, which is at Villa Beretta. And this has been essential for three main reasons. One is to have a continuous interaction with clinicians, both medical doctors in rehab medicine and physiotherapists. And on the other side, to reach really the patients and looking at the patients. This is the third part. Our students can observe what is going on in clinics before starting thinking, designing, and developing new ideas.
So you mentioned physiotherapists, which I find a very important part of any clinically valuable result. So that can be the engineer who designs a new technology, visionary doctor, but still the patient is often in the hands of caregivers and physiotherapists and students.
Yes, actually, the final end users of rehab technologies are the three people that you mentioned. So physiotherapists, caregivers, and the patient. And the way to engage all of them in a proper use of the technologies, possibly tailored on the real needs of the single patients, is a challenge. So yes, we work a lot with physiotherapists, and we think that their contribution is really essential and can give the value.
Franco, you are the director of research here. Tell me about the history of Villa Beretta and its future. Where are you trying to move it forward?
I started to work here a lot of years ago, but particularly 32 years ago, we decided to build up a movement analysis lab. Due to this, we start to have strictly connection with bioengineer because we introduced three-dimensional movement analysis, optoelectronic system, EMG, wireless EMG, and so on. And starting from this, we realized that without this collaboration with technological partners, it's impossible to change the way that we have to treat the patient. And progressively, we developed a very long-term collaboration with Politecnico of Milan. And due to this, more than 10 years ago, we start to have joint lab with Alessandra inside our rehabilitation center. And in the same time, due to this collaboration, we developed a model of collaboration. And now we have a 20 years partnership with new lab inside the campus of Politecnico of Milan in Lecco. That means that this rehabilitation center is focused on human, but using all the facilities that we have now to support human life and to restore function, and particularly human function. Human function that is motor control, cognitive control, emotion, social relationship, is more than a movement, is the ability to have action and interaction in the loop. Due to this, I would like to stress that the team that will use technology in rehabilitation obviously will have the physiotherapist as a key actor, but we have speech therapists that use new technologies. We have neuropsychologists that use technology, psychologists that use occupational therapy, and sometimes caregivers too. Then is a real interdisciplinary team, real, and in this moment, due to some technologies and particularly implanted system too, we need humanities too, because you are changing the feeling of the body of the patient. Then humanities means a philosophical approach to the problem that is very important to learn, relearn, educate, and to build up the best team to support patient, caregiver, and family for a long-term trip. This is another key point. Our approach is not to solve a problem and to stop after 1 week or 2 weeks or 1 month. It's like a drug. I start to have a drug for an infection for 1 month, then I stop. But if I have to support a patient with diabetes, I have to have a long-term perspective. This is exactly the same for technologies. To have, when we start, and to have a long-term perspective to manage the interaction between patient, the team that have to support the patient, and the real life of the patient and the family of the patient.
You mentioned formation. As far as you know, you started a new master course to form students on this at this interface between engineering and clinics.
Sure. The master, the director of the master is Politecnico of Milan and Alessandra. I am a clinical co-director, and this year we have a neuropsychologist too from Switzerland, Michela Bassolino, with us. The master is exactly a way to try to identify, in terms of education, a place where people with different background are around the same table to focus on the patient.
Villa Beretta is an impressive place. It's a nice building and fantastic facilities, but it's also surrounded by a great environment. It's up on the hill, by the lake, by the Alps. And I wonder, how important is this psychological aspect to a beneficial rehabilitation?
We are here due to a donation. Beretta family donates to we are a non-profit organization. Donate around 70 years ago this place to build up an hospital. And green area, very nice place, 70 years ago was due to serendipity, because if Beretta family was downtown Milan, we will have downtown Milan a place. But now, due to exposome research, we know perfectly that the light, the sun, the sound, the green are very important to define how we interact. Mm-hmm. And we know perfectly that perform the same exercise in a different place will have different results. For example, there is a very nice study that demonstrates that the room with garden view in a general hospital after surgical procedure reduce the rate of infection. And this is very important. Where you are and what are you doing is not exactly the same. Performing 1 hour of gait training in a garden or in a tapir run is not exactly the same for our brain. That means that is continuous of action and reaction inside our brain, looking motor control, but emotion related to motor control, cognitive control of the motor control and the emotion and so on.
Okay, but then the obvious question is, if so many factors can influence results, and given there's anyway abundance of results in literature, both in terms of therapies and in terms of technologies, how to interpret that kind of data, how to make sense of results that are influenced by little subtle environmental cues.
Statistics helps and is the, let's say, the basic for confronting with this variety of factors and try to make sense of comparison across multiple different solutions. And of course, I'm not a biostatistician, but there are specific design of clinical trials which address these issues. But anyway, I think that a piece of, let's say, artwork will always remain. I mean, you can have scientific evidence, and it's important to validate devices and to prove scientific evidence, but then the use of the device is always in the hand of the final end users, and they can put these special ingredients that might be active for that patient and not for the other, depending on specific characteristics. So I think evidence-based medicine is something we cannot at all reduce as the fundamentals for the science and the technologies to enter into clinical practice, but having the acknowledge that there is something that can be added to the single conditions. And sometimes it is telling a story or having a nice view.
Related to this, how obvious is that a patient who's showing some benefits of rehabilitation during a session at the clinic can bring that benefit at home to the same degree of improvement?
This is a key problem, to transfer all the information that we have during a clinical trial inside a rehabilitation hospital in a lab to real life. Generally speaking, is exactly the problem to use real world data to demonstrate the efficacy of a treatment. It's not so easy due to different reaction depending on maybe social condition, economical situation, and so on. That means that we have in some way to try to be able to differentiate the answer to the that we would like to have when we have a scientific question, depending on the level of ability to manage clinical lab and real life of the patient. In clinical lab, maybe, for example, I have weakness on the shoulder. I have a robot able to support me to train the shoulder. I am not sure that if the patient relearn to use the shoulder in the lab, will be able to use the upper limb in real life, depending from a lot of different reasons. Then, first step, we have weakness on the shoulder, impairment. I have a technological support to train this impairment. Are we able to increase the efficacy of the treatment to reduce this impairment? Yes or no? Typical clinical trial. Then, when you restore activity on the shoulder, you will have more ability to manage daily life activities. Second step. And maybe that we have a lab where we reproduce activities of daily life. Then, at home, you are really able to use your upper limb. Then again, technologies like sensors, able to detect activities in the real life. Different steps.
Technology-wise, I think there are a couple of directions which are very important to help the uptake of what has been achieved in the clinics to real life. And they deals with the concept of ecological treatments, and they can be on the way of having technologies fading away during rehab treatments. So like the robot helps, and the more the patient is learning, the less the robot helps, and let's say cope with the capacity of the robots and of the patients, and then try to become more and more transparent, so to be closer to the final conditions. And the second one is, which is, I think, a very important challenge these days, is about the continuity of care, which deals with the use of wearable devices, so to keep a monitor on the patients after discharge, to be able to understand whether the patient is leveraging on what he or she has achieved, or is in difficulty in using this at home. So wearable sensors and simple devices which might be at the cross border between assistive technologies, so helping patients doing daily tasks, and continuous rehab.
I've seen some experiments of yours, maybe a bit old now, but I found it really interesting when you placed some smart glasses on patients to see what the patient was seeing. What was the idea there?
This is very important because visual motor control is very important, and in the same time using new technologies able to detect eye tracking. You have some more information about attention of the patient and maybe engagement and motivation of the patient too. Then is another way to try to look how patient and person interact with a technology or with another person too through a technology. Then it's very important, this possibility to monitor eye tracking too. And in the same time, we have to realize that we need new technologies for inpatient rehabilitation that we have to use in a specific place without any possibility to transfer these technologies in another site. We need some technologies for in and outpatient clinic, then under control of the clinician inside the rehab center. Then we need technologies able to support the patient at home, outside the clinic. Then means that we will have the possibility to build up different technologies with different place where we think that we will use these technologies. This is another key point when we plan to have a new technological support for our treatment. Mm-hmm. In the same time, we need some technologies able to follow the patient from the beginning to the home. And as Alessandra mentioned before, on the border between technology to treat or assisted technologies or technologies to maintain the results that we reach. Then it is a very global scenario that we have when we talk about technologies for rehabilitation.
I like that when you describe these technologies, whatever technology might be, you really put an emphasis on the interaction between technology and patient, its role as a mediator, as a facilitator, not as a substitute for a specific function. Is this wording, this careful wording that you use, specific for, does it hide like a philosophy in your research?
No, absolutely. All the technologies that we are using are in between the intention of the person and the action that we would like to realize to interact with something. Maybe the intention of the person that we would like to treat, or the intention of the team that would like to treat a person, that will use a technology as a bridge. In any case, technology is a bridge in between intention and the real world and real life. And this bridge is very important because sometimes the intention without the possibility to do something is just an intention. We would like to realize the intention.
Alessandro, these are very psychological and clinical considerations, but how can they be taken into account when it's time for an engineer to think of a new technology?
The shift of the paradigm that we are seeing is from sensory motor loop to an intention action perception loop. And in this way, I think technology needs to be in the loop and activate the loop, considering always the whole story. And for example, we have worked on a lot of using functional electrical stimulation. Functional electrical stimulation means we are artificially activating the muscles to produce a goal-oriented task, so a real task. And so if we can align the use of functional electrical stimulation with the intention of the subject, this alignment produces not just the execution of the task like a robot can do, but also the execution of the task with the muscles of the subject itself. And so again, going through action to perception. And the perception is not just about the task done, but it's about the recruitment of the muscles, of your own muscles, to do the task. So this is an example. For example, we have worked on using EMG, so reading the residual muscular activity of the patients to drive the functional electrical stimulation, so to align intention to assistance, to the technological assistance. And then we have studied that the brain of the subject do have specific activations when this combination of the volitional intention of the subject and FES are combined. And this activation in the brain is different from the one that we can record when FES is, let's say, applied on a passive subject.
What areas of the brain, what centers of the brain one should look at when testing these kind of rehabilitation approaches?
We used functional magnetic resonance images, and the areas that we were capable to associate to this combination of FES and volition were in the M1 and S1, so primary motor and sensory areas, but also in the cerebellum. And actually in the cerebellum were recorded by a colleague of us, and also in the consolateral angular gyrus, where the sense of agency is developed in our brain, and in supplementary motor area, where the intention is developed for motor planning. So multiple areas in the brain proving that the whole motor action execution is influenced by this combination of FES and volition.
I want to come back later to the volitional part, and I'm not surprised that the motor and the sensory cortex are involved, maybe this is a general question, but what is proprioception? It's not necessarily a motor sensory cortex mediated feeling. I don't know if it's a feeling, but it's clear to me that even a person with a perfectly functioning motor cortex would have troubles moving if they don't have a correct sense of proprioception.
Proprioception is a fundamental part of the loop. And you have in sensory area something related to proprioception. Proprioception management is under control of the spinal cord too, for example, because the connectomics on the brain, a perfect example that Alessandra used before to define when I am looking functional electrical stimulation, I have to look M1, S1, prefrontal cortex, visuomotor cortex, then you have a connectomics. Connectomics on the brain and connectomics inside the spinal cord too, all together produce the fine-tuning of proprioception. Proprioception is something related to movement of a joint, the amount of lengthening of the muscle, and maybe mechanical stress on the tendon, and all together produce the sensation of the movement of the body and the position of the body in the space, but have to collaborate with other parts of the brain related to the perception of the space per se. Then peripersonal space and proprioception are strictly related. Then we are introducing, when we start to discuss in this way, the problem of the sense of agency, but the sense of embodiment of the technologies that I'm using inside my body to perform something that I would like to do. Then is the embodiment of the technologies is very important, because sometimes our patients have a disembodiment of the part of the body that we would like to restore functionally. Then if you have a disembodiment, we have some questionnaire, very nice answer from questionnaire about how you feel about your hand. Sometimes the patient says, it's not mine. I don't like it.
What is a draw yourself test?
Absolutely, it's possible to use to draw, to test something like this, but you have specific questionnaire. We have a very important collaboration with Andrea Serino and Michela Bassolino in Lausanne, focus on this. The body distortion and the body image are very important, as well as proprioception. You have a perfect proprioception and the body distortion. Then you have a mix, very difficult to manage. And that means that we have to manage the complexity of sensory motor cognitive control. It's very difficult to explain all the different parts. And in the back, you have the autonomic system 2. Autonomic system 2 is a regulator of the, for example, the prefrontal area. Then we need more information from sensory part of the body, motor control, cognitive control, and autonomic system 2. And now we have sensor able to do this during exercise, not only before and after.
Interesting, complex.
It's complex, absolutely.
We mentioned functional electrical stimulation. Let's get into the details of that. What is it and what makes it functional?
So functional electrical stimulation is the use of electrodes and a stimulator to send a quantity of charge to move the ions underneath the skin of the subject, so to produce the contraction of the muscles. So it's a way to artificially produce a contraction of the muscles when it is functional, when it achieves a functional goal, so a functional task. So we use FES when we are supporting by artificial contraction the execution of a task, possibly in a synergic way, so using multiple muscles. walking, gait, cycling, or arm reaching. So it's not just stimulating a single muscle, but is about stimulating the synergic activation of multiple muscles to achieve a functional task. And it produces the contraction of the muscle eventually. And so it activates the feedback loop from the contraction of the muscle, so proprioception, which achieves the brain associated to the task. And this is something that active physiotherapists cannot achieve. So it's the only way we can produce the contraction of the muscles. So if most of the technologies in rehab have been inspired by mimicking what is the traditional approach of physiotherapy assisted treatments, the use of functional electrical stimulation goes beyond this point because it activates the muscles.
It activates the muscle by stimulating the muscle or the nerve that connects the muscle?
This is a fine question. It depends on the neuromotor condition of the single subject. Usually we activate the nerve, which are mixed nerves innervating the muscles because the nerve thresholds are lower. But if there are specific conditions where the nerve is not answering, you can increase the level of stimulation and reach the muscle itself. So usually nerve.
When stimulating a nerve, now my neuroscience is a bit rusty, but isn't the sensory threshold lower than the motor threshold?
Yes. So to achieve the real activation, the direct activation, you are also activating a sensory afferent.
Isn't this undesirable? So you are forcing the movement, but you're also sending a message upward to the brain, that a sensory message, sensory information that maybe shouldn't be there.
There is a collision problem. Overall, we are activating sense afferents and efferents fibers, that's for sure. This is one of the limitations of using external stimulation. So no doubt that our brain is much more clever than what we can do artificially. It can activate only the motor, and we are not able to do that. It can make turnover of fibers, so to limit, to engage fibers, different fibers to keep the action, and so managing fatigue much better. And also it can activate fiber asynchronously, while with the stimulator we have a fixed frequency. So it's not exactly as activating the muscles by the natural path. That's for sure needs to be clarified. Thank you for asking.
Maybe that it's possible to try to define a different way to produce a single movement, or to produce a pattern, or to produce a monolateral pattern or bilateral pattern too. Then you have different level of stimulation complexity, but in the same time, maybe that, for example, I have the drop foot, maybe possible to stimulate the nerve on the popliteal area to produce dorsiflexion, or I would like to produce cycling. I have to stimulate a lot of different muscles, or I would like to modulate the control. I have to stimulate at epidural level. It is completely different. The place where I put the electrode and the system that I would like to stimulate to produce the activities that I would like to support.
Despite this complexity, we can, with FES, produce a desired movement. And that works for sure instantaneously. But there seems to be regenerative effect, something that is more long-lasting, even after the stimulation session. Why is that?
Oh, this is strictly related to the neuroplasticity. And from a biological point of view, it's fascinating. The idea that using artificial stimulation, you change the relearning ability of a patient, then means that you have a direct biological effect of the artificial stimulation, able to restore synaptic connection that produce a new ability of sensory motor control, and then means that it's possible to use stimulation for 1 month, 2 months, 6 months, and then the patient will stop due to the fact that relearn. Or maybe that it's impossible that the patient relearn the specific action that we are stimulating, but the continuum of care using electrical stimulation facilitate a new biological reaction in terms of intensity of the activities that you are able to perform. And for example, now we know that if we have intensity of muscle activity, we produce biologically some molecules able to have a cognitive effect. Then maybe that you are looking in action and you have an effect in a different part of the brain. Or maybe that using electrical stimulation and wearable robotic system, you are able to restore the ability to control gait due to activities that you are able to manage in standing position and so on. You improve bowel control, or you reduce pain, or you improve the well-being of the person, depending on the ability to change your ability to manage the position of the body in the space and to have a different peripersonal space and different interaction, social interaction too. That means look the first step, but look all the possibility that you have to have just something more than the first action that you are able to detect at the beginning.
So this long-lasting effect,
long-term potentiation,
is what is historically called the carryover enigma.
Yes.
Is it still an enigma, or this is the explanation?
The enigma doesn't deal with, there are a lot of people working on that, and some parts of the enigma has been clarified. For example, Matija Milosevic proved that spinal interneurons activity is modulated by spinal reflexes, and spinal interneural activities are modulated by FES. So we can see at spine level that using FES something is changing. And the same as about the brain was proved by fMRI studies, looking at how brain modulates and changes when FES is applied, and that in both cases the combination with the volitional part was essential. And but carryover enigma deals with another aspect, which was that some patients benefit of the carryover, but some other didn't. And so who are the one who are expected to benefit? Because of course the selection of the treatment is very important. And so if you expect a person to benefit of a specific treatment with a carryover, you want to provide this treatment, while if there is only the orthotic effect, maybe the treatment can be focused on something else. And clinical parameters, clinical scores couldn't predict the carryover enigma. Actually, and I think these components has remained somehow not totally unveiled. And actually, we studied that and on chronic post-stroke patients, and what we by using fMRI studies, and what we could tell on this, even on a small number of patients, so I wouldn't say that it's a definite answer, was that when the patient was activating the contralateral gyros and the supplementary motor areas, and so when using FES, the patient brain is engaged in the sense of agency and in the planning of the movement, then the carryover was achieved. While patients not including FES in their plan and in their sense of doing the task were not having the carryover effect. And this is extremely fascinating, because somehow is about this intention, action, perception loop, which needs to stay together.
This is a fascinating area. Obviously, you have something related to the lesion that you have in the brain, something related to the information that you are able to produce to support reorganization of the brain. But then you have some biological steps. That means, what about the genetics of the patient to have neuroplasticity? We know that we don't have, unfortunately, the same opportunity per se. Then maybe that some of the problem related to carryover effects and so on will be related to epigenetic changes that we start now to monitor. Now we have some data related to epigenetic, but it's a real big data world that we start now to introduce in our ability to relearn something about learning processes. Then this combination between where is the lesion, extension of the lesion, anatomical connection that we disrupt, and how we use information is a part. And the biology of the system that we are looking is another part. And we have to try to combine both. Obviously, functional electrical stimulation is one of the most important possibilities that we have in combination with any robot, soft robot, ankle foot orthosis, orthosis for the upper limb, to restore the sensation of the patient to produce a movement that the patient would like to produce. Is very, very important. And we have a lot of clinical evidence about this. Unfortunately, we use less than we need electrical stimulation in clinical practice, unfortunately, because it's a very important, and then education to use functional electrical stimulation may be absolutely important, because you have non-invasive and invasive possibility, but non-invasive electrical stimulation will be very important, cheaper than other system, and very, very effective if we start to use early and we follow the patient for long term.
Talking about technologies, you design exoskeletons, and you use exoskeletons in rehabilitation and neurorehabilitation. Now I have a photo with me. This is a very old exoskeleton. This is from the 60s or the 70s at General Electric in the US.
Wearable.
Very
and
well.
soft.
Not really soft. Nevertheless, that was pioneering work. Now, 30, 40 years later, we can do things much smaller, much more compact, miniaturized, and lightweight. Yet, while I see some of these much more compact devices on academic publications, it seems to me that commercially, or in the normal clinical practice, patients still rely on something relatively big and heavy, something that is hard to put on independently, even considering that this person might have some weakness on the arms or on the hands. What is limiting the spreading of these technologies to really state-of-the-art commercial level? Where are we at, and what are the problems? What are the challenges?
There are many challenges, and actually, what we have in clinics is much better than what we see in this picture. And there is a lot of research and in these directions, both to improve wearability and to improve the rehab concept associated to the use of these devices. So exercise, games, motivation, assistance as needed, controls. But still I think there is another point that is about the capacity that we have to translate what has been proved, has been, let's say, developed and prototyped by labs and then tested with clinicians, with end users. And the last mile is about having commercial devices. And this last mile is not easy to be traveled, actually. Of course, there is a lot of effort also by academic institutions to found startups, spin-offs, and there, to my experience, of course, I see two aspects. One is the economic impact. So the market of rehab can be quite a niche market, especially if you are focusing on a small group of patients or anyway. So to my experience, what joint venture capitalists said, okay, let's do exoskeleton for workers. Of course, workers and low back pain is another wide. But of course, we can also think that doing that will, let's say, return also to rehab and to assistive technology. So I think it's a way to reach also the rehab, the biomedical, let's say, application. The other possibility is that you engage patients. So one of the best stories we have in our lab, which has really changed my way of working, was when actually 10 years ago here in Villa Beretta, a group of patients and family and caregivers came. They knew from local news that we were working on exoskeleton for the upper limb, and they came and said they were of the Italian Association of Muscular Dystrophy Patients. And they came and asked us, okay, you are doing fancy exoskeletons we were using BCI, gaze, eye tracking, functional electrical stimulation, so very edge technologies. And they said, okay, we are wheelchair bounded, and thanks to helps in the breathing, we have reached a much longer life. But these extra years are extremely impaired. And the relationship with the family and the caregivers is a lot impacted by our continuous request of help, especially because we cannot move the arm. So can you help us? And actually, after a few talking, we realized that functional electrical stimulation was not appropriate, that they were with the very heavy arms, and we started thinking, okay, let's try to do, but what exactly you need? Because we were thinking of put on the clothes or preparing meals, and we were saying, we'll never be able to do such difficult tasks. And they said, adjusting the eyeglasses, scratch my face, saying hello, changing posture. So very tiny actions, which are the reason for multiple requests. I mean, they took for granted that somebody helped them in the very morning, or preparing lunch, or going for hygienes, but in between, can we be autonomous in putting our go to work and put the hand on the desk? And then we realized that we could do something. That was an amazing story, with them always engaged in all the developing of the prototypes and testing all the ideas that we were coming here, coming in Politecnico, we going home, their home. And at a certain point we concluded, okay, we have a motorized exoskeleton mounted on a wheelchair and easily controlled by joystick, the same joystick of their mobile wheelchair. So they are super good in using it. And with voice control, so to go back to the wheelchair or go to the desk without really controlling step by step. They were super active. And then they said, okay, can you give us the bill of material and the design so we have it? No, we can't. Of course, it's no way that we can provide them this. And so we started a long journey trying to, everybody who was coming in the lab, I was saying, we have this exoskeleton, the patients are waiting for this, but we need to kick it off the lab. And time after time, once there was a visit of an industrial robotic person, and he came and he was initially saying, okay, good. And then he said, can I come again? Okay, please, you are very welcome to come again. And he started producing some tiny single joint motorized exoskeleton in his industry and sending us the single joint to test it. We were testing, and he would say, because you did it in a very academic way, but we need to go for a more industrial approach. And so we were kind of, okay. And sometimes they were not working, so we were proud, yes, it's very industrial, but not working. And then after a while, they closed their industry, and he called me. And actually, he called me and Marta Gandolla, who is a collaborator of ours, and told, okay, we have closed, so now we won't be so able to try and to test with you some new devices. And I said, but this is great idea, great news. So now you can do it seriously. And after a while, he called me back and said, you are the only one who said it's a great opportunity. So let's try. And now we have the first certified medical device with medical device certification, fully motorized commercial device by their startups.
What's the name of the startup?
Alliarm.
What's the name of the product?
Ali 06, I think.
But this also highlights the importance of asking the patient for their needs rather than trying to interpret what their needs might be.
Alessandra introduced a very important point because we are looking at pathway related to technologies in neurodegenerative disease to assist daily life. But we have another part, technologies to restore function and to restore the ability of the patient to perform the function. Then just for a part of the life. In technology like this one, very important because follow the patient for years. The other one may be technologies to restore function as soon as possible, very quickly, during inpatient treatment or a short outpatient. Then very important to have the needs of the patient, but very important to have the scientific background related to how it's possible to restore function. This is unrelated from the patient needs. It's related to scientific background that we have to use. If you have hypertension, you don't know how manage hypertension. Someone has to support you using the drug and lifestyle to do this. This is another story. Then, assisted technologies for neurodegenerative disease is a very important part. Technologies to restore function is another part, with maybe a different market too, and maybe a different way to define the clinical efficacy compared to this one. And in the same time, the economical effort in the back to have these two different devices to restore and to assist may be completely different. In this moment, serendipity, it's okay, but we need some vision, focus on how to produce something to assist the patient for years, or how to produce something to treat the patient in a specific moment of the life during the pathway related to this stroke, traumatic brain injury, spinal cord injury, and so on. It is very important. Again, education of the people involved in both different ways to produce technology is absolutely important. The design is absolutely important to use it during daily life. The design is very important to use it in a clinic. If I have to spend 30 minutes to wear a system and I have 45 minutes to treat a patient.
So if there's something to take out of this conversation, is that it's a very complex area. One must take into account the clinical, psychological, engineering framework, the legal framework, all these pragmatic and medical considerations, as well as the difficulty in validating the clinical effects. In this complexity, often engineers thrive and they get excited because they can find new solutions. And thank God for that. When it's time to then translate those technologies into clinics, then it's time of the clinician to amplify that. And sometimes there's some resistance on that side. Also, it's expected from a doctor, I think, some caution with respect to the enthusiastic attitude of an engineer. But do you think this little resistance is too much, should be changed? Or where does it come from?
You have a resistance from the clinical point of view, this is true. It's mainly related to the fact that sometimes the clinician look the technologies something different from the field where they are really involved. In the same time, maybe that the clinician don't understand exactly the possibility that technologies are able to put on the table to treat a patient, then maybe that discussion with the engineer will be more starting from the beginning.
Would you say that a clinician trusts more a clinical trial for a drug than experiments on electronic technologies.
This is a very important point because we try to use exactly the same experimental setup for a clinical trial for a drug, and we would like to use it for technologies. It's not exactly the same. And then means that we have to build up some new clinical trial perspective when we would like to test a technology. This is another key point. In any case, sometimes you have some problem related to the economical situation that we have to face, the investment that you have to put on the table to use new technologies. But in the same time, this is the real life. Try to think, oncology, a new drug, maybe that the cost will be, but this means that it's an economical problem, but you try scientifically to look if this drug is working. And in the same time, we have to try to face the problem of technologies in real life, looking at the economical problems related, but not only the economical problem related. We have to look at the scientific problems that we have to face. In any case, more education, maybe more resources in rehabilitation, but particularly flexibility of the clinical team. Cognitive flexibility of the clinical team may be very important in this situation.
And when it's time to create trust in a technology and increase the adoption of a technology in clinics, words can be important. And I've heard you talking about robots, but calling them cobots. What's the idea there?
The idea is to have more collaboration between the person and the robots. The body talks, and the body of the patient have to talk with the technologies. A lot of information, a lot of data, then means fine-tuning of this collaboration. Artificial intelligence will be absolutely important. And maybe that due to artificial intelligence, we will change our ability to have this collaboration. And in the same time, all the data that we have may be a way through the umbrella of artificial intelligence, a way to demonstrate the efficacy in real world of the treatment that we are doing. Then means that the management of the complexity of the data through artificial intelligence will be a very important step to improve this collaboration inside the team, between the patient and the team, between the patient and technologies.
And what's your take on how AI will influence the data management and better therapies?
AI is entering in medicine as one of the major impacting force inside the development and the future of medicine. I think there are some areas where data are historically more rich and digital, where AI is maybe more ready to be adopted, and in some, for example, on images is already used. For example, on oncology, they are more prompt and ready. In rehab medicine, I think the historical approach of collecting data about patients has been less quantitative. And so, of course, AI needs data. And so there is a kind of catch up on this. But I think that we have to consider two aspects. One is that AI needs to become a colleague, so an interpretable and capable of giving reasons of suggestions, of the suggestion that is producing. And this component of explainable AI is essential for applications like healthcare. And the other is about validation. Validating AI tools in medicine is a mandatory step. And the more we are going to generative AI and complex AI, the more validation is a challenge. But is a challenge that we must take, and not is a challenge too difficult to be taken, because it's something that we cannot miss. And I think research, computer science research, needs to make deeper study about how we can explain and validate AI tools. And these aspects will open the possibility of a real adoption of AI tools for example, the tailoring of treatments. We have mentioned, we have clinical trials, we have many technologies. In rehab, each patient is really different from the other. And also because we talk about post-stroke patients, but then the size and the area of the brain are different. And so we can easily understand that they are not a uniform category. They are a very variegate category. And so if we can use AI to help in this understanding of the differences and reasoning about the confrontation between the possible treatments and the characteristics of the single patients, that would be great. And on that, I think that also, let's say, not the intelligent part, but the huge amount of previous knowledge and the selection of the most probable solution, which is what LLMs do. So they look for the most probable next. So probability has a lot with the clinical selection of treatments. And so I think they can play a major change, but validation and explainability are the key aspects.
Are key aspects for personalization of the treatment, for prediction of results, and maybe a key aspect for validation. In the same time, at the end of this very nice discussion, maybe that we have to stress that we don't like to build up a cyborg. We would like to maintain human value as a key factor to develop technologies. Maybe that we would like to use humanoid robots too. Why not? But maintaining the human value as the key factor that produce new technologies, and human value that produce the validation of the technology that we are using. That means that we have to move deeply on the biological aspect related to this and on humanities related to this, to be able to introduce in the real world a lot of new technologies that will have a real impact on the well-being and the real life of the patient. And due to this, it's possible to support healthcare systems that have to face a revolution due to aging population, due to, very recently in Lancet, they say that in this moment, due to neurological disease, from 2 to 3 billion people needs rehabilitation. How to support and healthcare that support a lot of the needs is not so easy. The technologies, we need absolutely technologies, and to maintain human value on the center of the table.
And the patient-centered. We want to go beyond the patient-centered. The patient is in the center, but never alone.
Absolutely.
So it's all about the patient and the relationship and the network of the patient, the clinicians, the family, the caregivers, and the community around the patient. So this concept that technology is not as a tool to become independent, but to become able to interact.
This is very important. Don't look technologies to stop to take care to someone, because this is it's okay. It's a different story. Maintain on the loop the social interaction,
enabling social interaction by using technology.
We like to conclude our interviews by asking our guests a book or a movie that can be related or not to your research, but that you would anyway advise anyone to read or watch.
About the book, my suggestion is to reread. For Italian people, is a mandatory reading at school. So, but please reread it. I Promessi Sposi by Alessandra Manzoni, which in English is the Betrothed. And the reason is because I think we are in a very performance society and very with the, let's say, low value of the time passing, while we need to give value to the time and the fact that great achievements might take time. The movie about the one that I often suggest to my students is Temple Grandin, which is amazing to try to experience the way autistic people feel the world.
Do you have a suggestion as well?
The book will be 6 Memos for the Next Millennium of Italo Calvino. It is a very important book from scientific ability to have a vision how to use the technologies. It's unrelated to technologies, but will be strictly related to technologies. And the movie Forrest Gump.
A classic. Thank you. It was great to have you here.
Thank you.